Okay, so I see a lot of people who liked my last video. Super incredible, you guys. Thank you so much for your support. I was reading through some of the comments and I found this one. Thanks for mentioning this. It actually gave me a video idea. In this video, I'm going to be talking about anemias. This video is based on what DirtyMedicine taught, and it's based off of what I learned in UWorld and first aid. And there's going to be some components of Pathoma. Now, keep in mind, this video serves as everything you need for board preparation, specifically like Step 1 and COMLEX Level 1. It might not be as comprehensive for your in-house exams. Let's get right into this, but first, if you're new, definitely consider subscribing. All right, so the first thing that we have is anemia, right? So I'm just gonna be talking about anemia here. So anemia is broken down into three categories, right? It's either microcytic, normocytic, and macrocytic anemia. Also, I'm really sorry if my handwriting's trash. So I'm just gonna draw arrows like this. All right, so microcytic anemia just basically means that in your lab values, you're gonna have a mean corpuscular volume of less than 80. So basically it's a low MCV, right, less than 80. Normocytic anemia is when your mean corpuscular volume is gonna be within normal limits, right? So it's between like 80 to 99 or whatever. Right? So then macrocytic anemia then is going to be a higher mean corpuscular volume, so high MCV, greater than 100. All right, so let's start with microcytic anemia, right? The first, there are basically four conditions to think about. The first one's going to be iron deficiency anemia. Okay. The second one's going to be sideroblastic anemia. The third one's going to be thalassemias. Fourth one's going to be anemia of chronic disease. The thing about anemia of chronic disease is that it's there in both microcytic and normocytic anemia. So I'm going to put it in both normocytic and the microcytic category. But for test-taking purposes, they typically ask about anemia of chronic disease in the context of microcytic anemia. So that's where you really have to focus on, like if you wanted to learn about it, it's probably just going to be, they're asking in the context of a low MCV. All right, so the first thing about iron deficiency anemia is that basically there's a lack of iron, right? So if you have a lack of iron, that causes a failure to produce hemoglobin, all right? So it can't produce, the body can't produce hemoglobin because of a lack of iron, okay? The main thing to understand about that is your lab values. So if you look at your lab values, so the first thing obviously is gonna be your MCV, but then from there, always check your lab values for ferritin, transferrin, and TIBC. Well, TIBC is basically transferrin, so they're kind of interchangeable. In your iron studies, you'll have a low iron and then a low ferritin and an increased TIBC. Okay. The other thing that they might talk about is your peripheral smear. And in your peripheral smear, you'll see hypochromic microcytic anemia. So basically what that means is that it's hypochromic just means that the blood cells are more pale in comparison to normal blood cells, like red blood cells, okay? So boards love talking about clinical associations, okay? So in green, what I'll do is I'll put the clinical association that you definitely should keep in mind because they might ask a classic board question about it, okay? So one clinical association is definitely Plummer-Vinson syndrome, okay? Basically, it's a triad of esophageal webs, iron deficiency anemia, and dysphagia, okay? So that's the first one. The second one that I've seen in my preparation is infection definitely can cause this. And then peptic ulcer disease can also cause this. And then another example would be menorrhagia. Okay, so those are your four clinical associations, and that's basically it for iron deficiency anemia. Now let's move on to sideroblastic anemia. What's happening is that there's a failure to produce heme. So failure in heme production, right? And because there's a failure in heme production, there's not going to be any hemoglobin. Because heme can't be, if you don't produce heme, it's not going to integrate properly into hemoglobin, right? There's 3 etiologies that can cause sideroblastic anemia, right? The very first one, actually let me use this, is a decrease in ALA synthase, right? So that's the first etiology. We can cover I'll probably cover the heme synthesis pathway in another video, but DirtyMedicine also covers it if you want to check it out. Second one is going to be deficiency. That basically prevents the functionality of ALA synthase. And the third etiology that boards like to ask is lead poisoning. So if you have an increase in lead in your body, it inhibits ferroketolase, which is an enzyme in the heme synthesis pathway. All right. So like I said, whenever you have microcytic anemia, always check the labs. The pertinent labs would be increased iron, right? Increase in ferritin because there's an increase in iron, and there's a decrease in TIBC. So why is there an increase in iron, right? So basically iron isn't properly being incorporated in heme, okay? Because iron is very much needed in the heme synthesis pathway, you have an excess of iron within your cells, okay? Particularly within the mitochondria, red blood cells, okay? And because of that, that's going to produce a characteristic peripheral smear, right? So in your peripheral smear, you'll see a characteristic finding of ringed sideroblasts. So I'm going to put this here, ringed sideroblast. That is very, very, very high yield, okay? So basically what does that look like, right? So you have your cell right here, ringed sideroblast. It has it's basically a halo of iron around that is due to accumulation of iron within the cell. So it literally looks like this. All right. And I can put it in the video right now. All right. So that's basically it for sideroblastic anemia, right? So we're done there. Now we're on to thalassaemias. Okay. Basically thalassemia is a very genetic condition. Hemoglobin is 2 different subunits, and those 2 subunits are produced by 2 different genes, okay? So basically, you have an alpha chain, right, and you have a beta chain, okay? If either of these don't get produced, that basically produces a thalassemia, all right? So there are multiple thalassemias, all right? This is the most annoying one, right? Med students really hate learning this, and that's why they ask about it a lot in your board questions, okay? And they'll ask about it in your actual step 1 exam, all right? You can break it down into either alpha thalassemias, right, or beta thalassemias, all right? There are 4 deletions that can happen for alpha thalassemia, right? If there's 1 deletion, it's basically asymptomatic. If you have 2 deletions, it produces mild symptoms. The thing to know about the 2 deletion alpha thalassemia is that there's a cis deletion and there's a trans deletion, okay? If it's a cis deletion, Asians are more likely to get this. If it's a trans deletion, then African Americans are more likely to get this. That's the clinical tie-in that they're probably going to ask about that, all right? The next one's going to be 3 deletions. This is more major, right? This is severe alpha thalassemia. And then if there's 4 deletions, it's incompatible with life. You'll see a very, very important tie-in called hydrops fatalis. All right. Then we have beta thalassemia. Beta thalassemia is more simple to understand. Again, there are multiple deletions. So if you have 1 deletion, beta thalassemia minor, right? It's not asymptomatic, but it's beta thalassemia minor. Okay. If you have 2 deletions, then you have beta thalassemia major. This is the one that's more symptomatic. You'll see all the classical findings, right? You'll see an increase in HbA2. You'll see chipmunk facies, which I don't see how it looks like a chipmunk. But basically what happens is because there's a lack of functional hemoglobin, there's going to be hematopoiesis, proper hematopoiesis that's going to happen extramedullary, like in the extramedullary spaces, right? So it's going to be extramedullary hematopoiesis, particularly in the skull. Okay, cool. So that's thalassemias right there. And then lastly is going to be, also for thalassemias, you don't really look at your labs. It's a genetic thing, okay? So they won't necessarily give you lab findings, and lab findings won't really be helpful in this case. Lab findings are usually helpful for iron deficiency anemia, sideroblastic anemia, and anemia of chronic disease, all right? Which allows us to segue into anemia of chronic disease, right? Basically, what's happening is that there's a chronic inflammatory process, right? There's some kind of like chronic inflammation happening, right? Chronic inflammation, either due to like a malignancy, some kind of long-standing infection, or any kind of inflammatory process, right? Basically, what's happening is that the body is producing this molecule known as hepcidin. All right, it causes less iron to be absorbed in the gut. Okay, and the other thing it does is that it increases iron storage. Okay, so because of these two things, there's going to be an increase in ferritin. So it doesn't matter if it's an infection or an autoimmune process. Actually, let me also add autoimmune, because it can be autoimmune like lupus or whatever, right? So it doesn't matter if it's an infection or autoimmune. This is the basic pathophysiology right there, right? So in your labs, it would be decreased iron, increase in ferritin, and decrease in TIBC. This is the only condition in which you see ferritin and iron being opposites. Okay, if you notice the other ones, ferritin and iron are basically in the same direction, like they follow the same pattern. Okay, so that's anemia of chronic disease. The main organs that cause the disease, clinical context, right? It can be a kidney patient, it can be an autoimmune condition, and then it can be a rheumatologic disease. Okay, I kind of talked about anemia of chronic disease. Symptomatic anemia of chronic disease is a later, like it's more advanced. In more advanced stages, that's what happens. Okay, anemia of chronic disease is normocytic in the initial stages. Okay, so that's the first thing. The second disease then would be paroxysmal nocturnal hemoglobinuria. Okay, so basically what happens is that there's a mutation of the PIGA gene. I don't know the actual name of it, but it's called PIGA. It's going to cause a deficiency in CD55. CD55 is also known as delay accelerating factor. All right, so I'm just going to call it that. And there's also a deficiency in CD59. Okay, CD59 prevents the terminal polymerization of the membrane attack complex. So it stops polymerization of C9 within like the complement system. Because of that prevents the membrane attack complex from forming. All right, so if you remember the pathway, right, you have a red blood cell. Okay, you have CD55 and CD59. Okay, so what happens is that C3 convertase is going to be formed. Okay, and it produces C3b, which then produces like it activates like the C5 through 9 system, and that produces the membrane attack complex, right? And that's what usually causes lysis of the red blood cells. The point of these two is that these will basically inhibit the membrane attack complex, all right? Therefore, it prevents lysis of red cells. Okay, so if you have a deficiency of this, then there's with PNH, you basically are gonna produce more MAC. So the MAC functionality is gonna be on, like there's gonna be a functional MAC on the red blood cells. Therefore, increased lysis of red blood cells. All right. And DirtyMedicine actually has a great mnemonic for that, right? So the classic findings, right? If we look at the findings, it's basically, you have to look at the first letters of this condition, right? PNH. All right. So the main things to look at is pancytopenia. Pancytopenia, again, is just like decreased red count, decreased white count, and decreased platelets. Okay, so all across the board, all of these blood cell components are lower than normal. N, it stands for negative Coombs test, and H stands for hibernation. Okay, so what does that mean? So basically what's happening is that patient with PNH will undergo hypoventilation, right? And that increases complement. So at night when they're sleeping and stuff like that and they have hypoventilation, they're gonna have an increase in the complement cascade, and that produces symptoms of pancytopenia and all that, and that causes normocytic anemia. They'll present with like fatigue, weakness, and everything. Third condition is going to be G6PD deficiency. So what happens is that there's some kind of oxidative stress. And that's the key thing that you have to look for. There has to be some kind of stimulus within the red blood cells. Okay, and so normally what happens is that there's normal glutathione, right? That basically gets converted by G6PD using NADPH. Okay, so when it takes NADPH and then it converts glutathione to reduced glutathione. Okay, and this guy is very important for reducing free radicals. Now this is the normal. Okay, if you don't have this, right, if you have a deficiency in this guy, then you're going to have increased free radicals, and that causes oxidative damage. And this is only in the context of oxidative stress. So what conditions cause oxidative stress? Okay, the biggest mnemonic that DirtyMedicine uses is D6P. Okay, so dapsone medication, right? Dapsone for like if they have mycobacterium, I don't know, like leprosy or some shit. Sulfa drugs, primaquine. There's also fava-beans, which it's not part of the mnemonic, but I just kind of remember that. That's that's something that I saw in my exam for Step 1. If you remember dapsone, you can also remember isoniazid, right? And another, like these ones over here, fava-beans, INH, and nitrofurantoin would be another one. These aren't part of the mnemonic, but they're good to remember too, okay? Just know that because those are also things that they can ask about. So let's talk about the findings. I forgot about that. All right, these are the classic findings. You have to know these findings. They're usually pathomnemonic. All right, you'll see, they'll probably ask about this in one of the answer choices, but you'll basically see Heinz bodies and bite cells. Basically, there's so much oxidative stress that there's going to be a bunch of like little dots within the red blood cells, right? And these kind of like coalesce in this area right here. And what happens is that splenic macrophages will take that and produce a bite. They'll literally take a chunk of that meat out, okay? And it will produce a bite out of it. Bite cells are a product of the removal of Heinz bodies by splenic macrophages. Another name for that, it would be degamocytes. Okay? Just in case they ask, for completion's sake. All right, I'm going to move this down here. All right, let's go over here. Cool. So then the fourth one is going to be hereditary spherocytosis. So in this one, basically, there's going to be a deficiency in one of the structural proteins that are found within red blood cells. So we're talking about spectrin, onkirin, I think that's how you say it, and the bands, okay? So basically what's happening is that because you lack the structural components, right, in the cytoskeleton, your red blood cells kind of look like this, right? These are normal red blood cells. If you were to take a cross-section, like if you were to take one of these cells and then just kind of cut in the middle right here and look at it from look into the red blood cells, that's how it normally looks, right? It has a biconcave shape, right? In hereditary spherocytosis, this structural component is lost. The cell becomes very, very spherical, right? Right, so that this is basically a spherocyte. Right, so this basically decreases the surface area to volume ratio. There's no central pallor either. Okay, so on a peripheral smear, they just kind of look like just a whole, like normal red blood cells kind of have a central pallor. Right, I'm gonna try my best to draw it in here. Right, this central pallor is because of the biconcave shape right here. So that's a normal, right? So on a peripheral smear, this would be a spherocyte. I would encourage you to look at it in your first aid. Okay, so this is a spherocyte. Okay, the other clinical tie-ins that you have to know is that it's negative Coombs test. It produces a negative Coombs test. The second thing is that It can cause splenomegaly. So why would it cause splenomegaly? Spherocyte, these guys can't, like, they get stuck within the spleen, right? Stuck in spleen, and that just kind of causes obstruction and congestion within the spleen, and that causes splenomegaly. The third thing is there's extramedullary hemolysis is what I meant to say. Okay, and because of that, you're going to see the patient being jaundiced. This is one of the few conditions that actually produces jaundice along with anemia. The fourth thing is that it produces Howell-Jolly bodies. So this is a complication from the splenomegaly, kind of, right? Anytime you hear the word Howell-Jolly bodies, it is indicative of asplenia. Okay, it can be any cause, right? This finding, this kind of like this buzzword indicates that there's like no functionality within the spleen. Okay, so the splenomegaly can actually become dysfunctional and just not work anymore because of the constant congestion, and that can lead to Howell-Jolly body production, and that leads to asplenia because now the splenic macrophages have no way of dealing with the problem. Okay, so that's hereditary spherocytosis. Okay, so now we're on to macrocytic anemia. For the purposes of this exam, there are both megaloblastic and non-megaloblastic causes. In megaloblastic anemia, right, the two main things to consider are B12 deficiency. The thing to understand about B12 deficiency, it takes years for any symptoms to show, okay? It takes years to develop any kind of symptom. All right, so basically here's your GI tract, right? This is your stomach, okay? And this is your esophagus right here. Is that when you consume animal products, right? B12 with animal protein or whatever, right? That gets exchanged with intrinsic factor, okay? Intrinsic factor allows it to go down to the ileum, right? So let's go all the way down to the ileum, right? So this is duodenum. So B12, the intrinsic factor allows it to be absorbed from the GI tract into the system, okay? So anytime you see B12 deficiency, one clinical association you should consider is pernicious anemia. These clinical associations have different pathophysiologies, okay? If you hear pernicious anemia, right, or if you see this kind of pathological progression, what's happening is that there's decreased parietal cells within the stomach, and that means that these won't produce intrinsic factor. Parietal cells produce intrinsic factor, which is important for B12 absorption. Okay, and so because of that, there's going to be decreased B12 intrinsic factor, and then because of that, there's going to be decreased B12 absorption. And so because of that, that causes decreased DNA synthesis, which leads to megaloblastic macrocytic anemia. The second clinical association that you have to know is you have to look at the history to see if there was a prior GI disease. So GI disease, or like gastric or ileal resection. Okay, so you can imagine, as we just talked about pernicious anemia, right? If you remove the stomach, then you're not going to have parietal cells, and you're not going to have intrinsic factor being produced. If you remove the ileum, then there's no way for the B12 to now be absorbed, right? So any of these can produce B12 deficiency. There's no way for B12 absorption, okay? And there's no intrinsic factor because you don't have parietal cells. So those are the important etiologies to consider. The other thing to really understand is your labs. Okay, so in B12 deficiency, you're going to have an increase in homocysteine in your serum. So serum homocysteine is going to be elevated. And the more important thing is that methylmalonic acid is going to be elevated. So increased MMA. Other clinical findings, right, at least in B12 deficiency, is you're going to have neuropsychiatric conditions. Subacute combined degeneration is a huge one. The biggest thing in the megaloblastic ones is going to be hypersegmented neutrophils. Okay, hypersegmented neutrophils. Okay, In fact, I'm gonna rearrange this chart a little bit now that I just discovered this, or kind of like realize this. In all the megaloblastic causes, you're going to see hypersegmented neutrophils. That is the biggest thing, that kind of biggest like pathognomonic finding. Okay, in both B12 and B9 deficiency. Right, so B12 and B9 are the hypersegmented neutrophils, and they're a part of a megaloblastic etiology. All right, so B9 deficiency, or folate deficiency, sorry. Okay, so less B9, right? It decreases DNA synthesis. The main etiology is going to be a terrible diet. Terrible diet. That's the only thing. All right, and there's not going to be any subacute combined degeneration or psychiatric syndromes. Okay, the labs that you have to pay attention to is that it has homocysteine, increased homocysteine levels, but there's no increase in methylmalonic acid. That is the biggest distinction between B9 and B12 deficiency. So in macrocytic anemia, we have two causes, right? I mentioned megaloblastic, but for completion's sake, there's also non-megaloblastic anemia, right? So non-megaloblastic anemia, the main clinical associations that you have to know for this is there's three main groups that I like to look at. The first one is going to be a cancer group. The main way to look at non-megaloblastic anemia is cancer-like etiologies, right? The second one is going to be organ dysfunction, or like some kind of like organ problem, right? And then drug-induced. And these three etiologies all fit under non-megaloblastic macrocytic anemia. So when we talk about cancer-like etiologies, myelodysplastic syndrome, acute myeloid leukemia is another one. To my knowledge, these are the more common cause non-megaloblastic macrocytic anemia. Liver disease would be the first organ problem, and then the second one is going to be hypothyroidism. Okay, the last one is going to be drug-induced, right? Drug-induced, the key drugs that I've seen in UWorld questions is hydroxyurea, zidovudine, and then chemotherapy would cause drug-induced non-megaloblastic macrocytic anemia. All right, so that's what I've seen in UWorld. I just wanted to add it here for completion's sake. This sums up my chart for anemias. First thing that you have to look at is whether the patient has anemia symptoms, right? Fatigue and weakness. Then you are probably going to get some kind of lab values. In this case, it would be MCV. That's your biggest sign, right? Low MCV is going to be less than 80. 80 to 99 is going to be normal. High MCV is going to be greater than 100. And that tells you whether it's microcytic, normocytic, or macrocytic. From there, you have to look at the clinical vignette. Usually for microcytic, you can look to see if there are lab values, and from there you can see what the ferritin values are, the TIBC or transferrin values. Those are the biggest giveaways. Sometimes they're nice and they give you peripheral smears, so that helps you with the diagnosis. Also, if you're attempting questions, one thing that you definitely can do is weed out a bunch of answers that you know it's not true. That definitely helps with like breaking down the question and improving your chances of getting it right. If you made it to the end of this video, thank you so much for your support. If you found this video helpful, leave a like. I'm down to make more of these videos. I definitely found writing out like the specific charts for different disease processes helps for developing like a clinical context of everything. So I did that for basically all the organ systems that pertain to step 1 and COMLEX level 1. So if you want me to make more videos, let me know. Put it in the comments below and I'd be happy to do that. I'll see you in the next video. Peace.